they appear both as an echoic implant with an echogenic shell. In the MRI, we use a silicon-sensitive sequence in which the silicon will have high signal, while the saline-filled implant will appear as a low signal. Second procedure is the breast augmentation by autologous fat injection. First, liposuction is done from any part of the body. Then the fat is processed and directly injected into the breast. The normal appearance of injected fat will appear as multiple lucent lesions in the mammogram, and it have variable appearance in ultrasound, either complicated or simple cyst or hyper or hypoechoic mass. And in the MRI, it will give fat signal. Breast augmentation by filler material. Filler by hyaluronic acid is the most commonly used worldwide, and the filler will appear in the mammogram as single or multiple well-defined rounded or oval dense masses, and in the ultrasound it may give complex cystic collection or simple collection in the retroglandular region. And by MRI, the filler material will appear as hyper-intense T2 signal collections in the prepectoral region. Now we'll see some normal findings in the most commonly used breast augmentation procedure by silicone implant. Here is calcification in the implant shell. Here are normal folding, which is called the radial fold, and here is minimal to mild peri-implant fluid collection demonstrated by ultrasound. Common complications of the breast augmentation procedures. First of all, the complications of the implant. The early post-operative complications is common between all the procedures, which either seroma, hematoma, or infection. Late complications of the implant is a gel bleed or capsular contracture, as in this case where the implant acquires a spherical shape and has a thickened capsule. And implant rupture is a commonly faced complication, which is either intra or extracapsular rupture. And another rare complication is anaplastic large cell lymphoma. Here is some imaging features of the breast implant complications. The intracapsular rupture. Here we can see the most specific sign for the intracapsular rupture, where multiple layers of collapsed shell of the implant are seen contained within the fibrous capsule, which is made surrounding the implant by the body. It has an appearance of a linguine. Another less specific sign of the intracapsular rupture is the keyhole, teardrop, and nose sign, where the small silicone bleeds are seen contained within the shell, between the shell and the capsule of that is made, fibrous capsule made by the body. Another associated findings in the intracapsular rupture is a water droplet sign, which is high T2 signal drops inside the implant. It is associated with other signs, but if alone, it is considered as degenerative sign. Extracapsular rupture is among the complications of silicone implant rupture. It is seen when the silicone separate from the implant and come outside the fibrous capsule made by the body. Another rare complication is the anaplastic B-cell lymphoma. It may be found in 80% of cases by a significant peri-implant effusion, as a demonstrated case, or in only 15% it may be present with a mass, and its prevalence is 1 in 30,000 cases. Now we will discuss the complications of autologous fat injection. Early post-operative complications are, as we mentioned before, seroma, hematoma, or infection. Late complication, the most common complication is breast disfigurement and unsatisfactory shape, and other complications are fat necrosis, sclerosis, and calcification. Complications of augmentation by filler material. The most commonly faced is unsatisfactory breast shape. and the breast lumps, if the procedure is done without sterile technique, inflammation and infection is encountered. And another complication is the gel migration. Here the gel migrated into the mediastinum, but this is a case report, but most more common sites of migration is in the subcutaneous skin of the abdominal wall and the pelvis. We will demonstrate some cases from the clinical practice. Here is case number 1, a 26-year-old female which comes with unsatisfactory breast shape after implant, and the technician suspected implant rupture. This is left breast. There is defect in the implant capsule. This sequence is silicone sub-breast sequence, and there is a defect in the implant capsule here along the lateral aspect of the implant. And here this is a stair sequence where there is massive edema and the subcapsular line where the implant is, the silicone is seen between the implant shell and the capsule, and the silicone appears degenerated and acquires abnormal signal. This is the other side of the breast, the right breast. There is a small contained leak which appears at teardrop sign where the silicone is contained within the implant capsule. Case number 2, this is a 38-year-old female coming complaining with recently developed right breast lump following breast implant. Here we can see a cystic lesion which has high stir and low T1 signal, and it shows here in the T1 post-contrast suppression images, marginal enhancement and a central restricted diffusion, and by ultrasound a complicated infected cyst was noted. Another case is a 44-year female patient which feels that the left breast implant currently feels firm and tight. Here we can see that the breast implant contour is currently spherical and has a thickened capsule. So together with the patient complaint, we suspect left implant contracture. Case number 4, a 25-year-old female with Poland syndrome and hypoplasia of the right breast and right chest wall muscles underwent breast implant 11 years ago, and now she feels that the implant feels painful and tight. Here we can recognize the spherical contour of the deep part of the implant, which appears elevated from the chest wall with a relatively thickened wall, and so we suspect with the patient complaint early implant contracture. Case number 5, a female with previous lipofilling of the breast, and then she was not satisfied with the shape, and so it is followed by silicone implant. The patient, here we can see the both breast augmentation procedures where here the fat, there is oil cysts at end stage of fat necrosis and appears in the ultrasound as a rim calcification of the cyst, and here is intact silicone implant. Case number 5, a 41-year-old female with a previous history of lipofilling. This is a typical appearance of fat filling within the breast, which is appears as multiple rounded and oval-shaped fat signal masses of high T1, T2, and T-breast in the stair and post T1 post-contrast fat suppression images. Here is the last case, case number 7, patient giving history of filler material injection in the breast and is coming with unsatisfactory breast shape. Here we can see the filler material in the retroglandular zone appears as multiple cysts or cystic collections which appear high in the T2 stair and low in T1 images. Here there is a complication which is the most common complication in the filler material, where we can found the filler material migrated to the inframammary zone, and this is ultrasound where the filler material appear as multiple cystic collection in the retroglandular region. Conclusion, the modality of choice in breast implant assessment is the MRI, either to assess the implant integrity or to assess additional pathology. In the lipofilling, normal lipofilling can be assessed by initially by the ultrasound and mammogram, but if additional pathology is encountered, MRI is recommended. But in the filled breast, it should be evaluated in a similar manner to the dense breasts with additional imaging modality, typically the ultrasound first, and if it is challenging, MRI is recommended. Thank you.